We wanted to make sure you could hear that. This is Steve Stites at the University of Kansas Health System, broadcasting from the Dolph Simons Family Broadcast Studio. So glad you're with us, and we're back with you this morning. On my right,
hi,
right-hand man, Dr. Dana Hawkinson, Dr. Hawkeye, our Medical Director of Infection Control, one of our excellent infectious disease physicians. And on my left is our special guest, Dr. Ronald Chen. Dr. Chen hails with us from the University of North Carolina originally, is now the chair of radiation oncology here at KU. And if you are a Rock Chalk Jayhawk fan, isn't it fun to take things away from UNC? It's the best. So, Dr. Hawkeye.
Hi.
Hey, what's going on out there this morning? How do the numbers look?
Hey, yeah, the numbers creeping up a little bit here in the hospital. We have 34 patients. Certainly the last few days it's been more around the low 30s, 30, 31. We do have 11 patients in the ICU, and 9 of those are vented. Again, we have had some people who have recovered and have been discharged and are home and well, but we still have some people that have been in the ICU and on the ventilator for a little bit of time.
Yeah, still, you know, coronavirus is still a tough disease, and it's really important in the Cancer Center, Dr. Chen, and I know that you have some important thoughts for our audience today about that, I think.
Yeah, I think as you said, I think coronavirus is a very tough disease, but I think it's especially important for cancer patients. I think a lot of things that you've talked about in this program, social distancing, washing your hands, keeping 6 feet away, it's important for everybody, but it's especially important for cancer patients because they are more vulnerable to develop the severe consequences of coronavirus. So there have been studies that have been published now that show that if a cancer patient catches coronavirus, they're more likely to have the severe symptoms or even die from this infection. Not everybody, but more likely. And so all of these efforts to reduce spread of this disease is really important for our cancer patients.
And I think it's really important just to emphasize cancer patients need to stay in contact with their health care. And you know, it's still okay to go to the cancer center and get care. Don't interrupt therapy.
I think that's really important. I mean, even with the coronavirus pandemic, cancer doesn't stop. And so for cancer, which could be a life-threatening disease, oftentimes people need to continue to get treatment. Certainly here at KU, we've been able to continue our radiation, chemotherapy treatments for our cancer patients. And so I think all the efforts to reduce the spread of this infection, which allows us to be able to continue to take care of cancer patients, is especially important.
And I think the good news is that because we've worked so hard, and I think cancer programs all over the country have done this, to keep patients safe, there are some specific protocols in place so that patients are safe from the moment they come in and get their care. Can you talk a little bit about some of those?
Yeah, I mean, I have to say, as you said, I've just joined the KU team about 5 months ago, and it's really been incredible to be part of this team and see how KU has adapted to this rapid situation. And I'm in daily meetings to talk about how we in the Cancer Center and we in the health system can really help take care of our patients and keep them safe. So a couple of things to emphasize. One, we've really ramped up telehealth. So telehealth is the idea where maybe for many of the appointments our patients have, you could do this by the telephone or by video or by the computer instead of having to come in person. We've really ramped up that effort throughout the health system and throughout the Cancer Center. And so I actually just did one yesterday, a consultation with a new cancer patient by video. It was actually a very good experience. It was about an hour conversation. He was able to ask all his questions. I was able to answer them. We saw each other for the whole time. And I think it works. It works to really communicate what we need to do for the cancer patients. It really helps also keep the social distancing and reduce the risk for infection. So that's really been important. I think the other thing that's really been important in terms of our effort is the no visitor policy. The no visitor policy is actually really difficult for the doctors and also for the patients, because I think for many patients, the family wants to be involved in the conversations. The family wants to be involved in hearing the treatment options. We can do that. We can actually do that by the phone. During the consultation, we can have the family members join by phone or by video instead of being in person, so we can really still involve the family as much as possible. But not having a visitor also reduces the chance for infection for the cancer patients and for our staff. So those are two of the major things that we've developed here.
And I think all the good infection control when patients walk in with masks and things like that. So, you know, we watch pretty closely, Dana, our infection control in different clinics. I don't think we're seeing a spike in infections in patients because they come to clinics.
Right. No, we continue to treat Our inpatients, just as our outpatients, we have really clear infection prevention guidelines to keep our patients safe and our other healthcare workers. So, yeah.
You know, the other thing, we just got our first swing of data at what it's like for patient satisfaction with telehealth. There's this big thing called Prescanian, and you get your patient satisfaction. We get it on a regular basis, and we measure it and follow it very closely. It's one of our 5-star performance criteria. And what we know is that our clinic's patient satisfaction scores with physicians and with staff, they actually went up. And it's interesting, and I think it's just because that in some ways, telehealth can be more convenient for some folks, as well as keeping them safe. So,
if I can add to that, I think telehealth may be ultimately a blessing from this coronavirus situation.
It's silver lining.
I mean, I think a lot of cancer patients want to seek our advice, want to seek our recommendations, but they're not able to travel here because they live far away. And telehealth will be able to expand their access to our expertise here. So I think that's really a great thing.
Yeah, in the long run, for folks who can't get to 39th and Rainbow or wherever we are, I actually think telehealth, especially in rural areas, is going to be incredibly important to health overall.
And I think I'd like to add to that, too. You know, we really try to treat, I mean, everybody is special. You're the patient, you're special. We take the amount of time we need to take to make you understand what's going on, to answer all of your questions, and sometimes we get backed up in clinic. I think if you're waiting at home for that call, if the previous telehealth call is a little bit later, it's probably a little bit better waiting at home than in a clinic room as well, so that might happen.
I've enjoyed it. I've been able to do a few of those sessions and have some next week too. So, well, questions from that are out there, reporters and media, thanks so much for being part of this and helping us with the messaging around coronavirus.
Good morning. Hi, this is Dave from the health system. I have just a quick question. A 4-year breast cancer survivor says she's never thought of herself as having a pre-existing condition. Should she change that mindset, and does having a cancer history put someone at a higher risk if they get COVID-19?
Not for patients who've had cancer and they're pretty far out from treatment, so maybe a breast cancer survivor who had treatment 5-10 years ago, probably not at a higher risk for the severe consequences. I think the studies that have been published so far, again, we're still all learning about the situation, but the studies that have been published so far indicate that patients who are newly diagnosed or going through treatment or soon after treatment are at increased risk for the severe consequences. The far out survivors, we do not know that they're at a higher risk.
I heard there was a media question I heard.
Yes, I'm sorry. This is Cindy from KCTV5. Yesterday on our news, there was a study out of, it was a news release out of St. Louis saying the researchers at the University of Washington predict Missouri will have more than 1,700 deaths by the beginning of August, and that's more than states like Washington and California and even larger states like Illinois. Do you agree with that grim prediction?
Right, you bet. Let's take on that. I think that's from the IHME model from the University of Washington in Seattle, and they've done a great job at trying to build models that are easily accessible for other folks to look at. There's a number of those out there, by the way. There's one called the CHIME model. We follow a lot at the University of Pennsylvania. Hopkins has a model. A number of consulting companies have models. The CDC kind of points in different directions. CDC actually and Anthony Fauci, they look at all these different models and tried to develop one. But the University of Washington model is one of the main ones, Dana. And what are your thoughts about that? You and I were talking a little bit about that last night.
I think the models are good, the projections are good, but they are all different. So I think you need to take the elements of truth from those. What variables are they looking at? Because that can determine a lot. What is the exact makeup of your population? That determines a lot. And so these projections are really made based on certain variables that people are putting in. They are, again, as Dr. Stites has talked about, it's probably easier to predict the weather than on these projections. And that's kind of the main takeaway from this. We take in all of this data, all of this information. Hopefully we can change that. But again, it is just projections.
And I would just to point out that the weather comment too was actually came from the author of the University of Washington model, or the leader of it, and he said that because, and this is what you have to understand, we've never had a pandemic since 1918 with influenza. So in a modern time, we have not had one. There are no models to predict how coronavirus will act. So instead, people that have been tried and tested, in other words. There are models, but as the guy there was the individual who said at the University of Washington, they are about as good as forecasting the weather. And, forecasting the weather in Kansas City can be a little iffy sometimes. And so I think that's the thing. You have to remember that information. The second thing is University of Washington model is built out off the number of deaths you've already had. And what they do is they compare it to what they think is going on in your area around sheltering and social distancing and all those other variables. But the University of Washington has to look and see, well, how has coronavirus behaved in other populations, whether it's in Seattle or Wuhan, China, or out in Italy or New York or what have you. And then they try to look at that and say, well, what are the best variables to predict the model? So number of deaths turns out to be a really good one. It's a delayed number, meaning that you have to get the virus, you have to get sick, you have to be in the hospital, and then you pass away. And that time thing, that tells you it's about 14 to 20 days behind the actual incidence of coronavirus in the public. We're still really early. And so a few deaths one day can markedly give you a new data point as they try to build that curve. And when they do that, a few deaths on one given day will suddenly force it up. Or if you don't have a couple of deaths for a few days, all of a sudden the model begins to flatten out. So it's really early to make bold predictions about what's going to happen. The model just throws out the data that says, look, based upon the number of deaths you've had on the number of deaths per day, this is where we think you're going to land. But we don't know that, and we won't know that for another few weeks. It's one model. Now, it tends to be one of the more conservative models, but it's very sensitive to the number of deaths you have, and if there have been more deaths for whatever reason early in the disease process, and that will affect how many that are projected. In addition, we don't really know because, remember, there wasn't a lot of testing in Missouri and Kansas, and as a result, we really weren't sure about the distribution of the disease and how many people had it right from the outset. So that's been a challenge. So the model has said like 1,700 deaths in Missouri, and that's really high, and it said like 500 deaths in Kansas, which is actually really high because Kansas, that's about the same population density if you look at the relative population of Missouri and Kansas. But it's going to take time for us to really find out if that's really true. The other thing I would just say is it just emphasizes the importance of trying to prevent spread of this disease until we have effective therapy and vaccinations available. And how do you do that? It's the same thing we always say, and we're so darn boring. I'm like the most boring person in the world. It's amazing I got married. But it's really about sheltering at home, 6 feet apart, washing your hands, cough into your elbow, don't touch your face. Those are the things we know make a difference. And we know, and when we believe we have started to bend the curve here in Kansas City, and because we did all those things so early, all those infectious measures, the full success of that won't be known really for months. Long-winded answer, but that I just wanted to make sure we covered all the good points there. It's a great question. Other question? I know I'd talked for a long time. You probably forgot your questions.
And this is Nate from the health system. I have another question that came in. Someone is asking, do we know if there's a plan to study ivermectin in treating patients with COVID-19?
Ivermectin. Okay, I'm going to look at you, Dana.
Yeah, I'm going to say there's no current plan to use ivermectin. There was a basic science research article, meaning in the lab, using cultured cells, so not a human, and it showed maybe there was some antiviral properties. It should be noted, if I remember correctly, they were using ivermectin concentrations that were not even approved for human use. So we are probably going to see a lot of these, and we have seen a lot of these basic science research, which are really good, but there are a lot of steps to take to get from the benchtop to human trials to actual efficacious results in humans. At this point in time, there's no plan to use ivermectin.
And we know that one of the first things that happens, Ron, anytime there's a new disease out there, is we try to repurpose old drugs first, because that's a lot easier than trying to develop whole new drugs.
Yeah.
But we're just repurposing drugs, and we've done this many times, and sometimes it works out, sometimes it doesn't.
Yeah. I think research is a really important piece of the conversation here. Actually, it's been really incredible to see the country and the world react to the COVID-19 situation, developing vaccines, doing experiments to try to find new treatments. So every day, I think we're going to hear another news story about a new thing that may work in the cell or in animals, that may work in humans. There are lots of clinical trials being designed right now. Some of them are going to pan out. Probably the majority of them will not pan out. And I think the clinical trials to be able to actually study the efficacy of these in human patients will be really important.
Yeah, just a comment. Coronavirus is the challenge of our time. It will define us as a generation right now. And we will not be the same on the other side of this as we were 3 months ago. And I don't think in our human history, short of, I suppose, of a great big asteroid crashed the Earth and all those things, I don't think we would really have such a rapid change and challenge to us. And we have to come together, as Dr. Chen has said, as best we can. And you know, the remarkable thing, the remarkable story is, when AIDS first presented, I was a medical student, and you know, we didn't know what we were doing. People didn't want to talk about it. It stayed in the closet for a long time. You know, it took 20 years to develop effective therapy. When Hep C was finally described, it didn't take 20 years to develop effective therapy. It was a much shorter time frame. And today, Hep C is a chronic treatable disease. When you have a world working on, with this singular focus, on a thing like this with a pandemic, I think it is truly remarkable how fast people have focused on it and how fast we've delivered already things that would have taken a decade only a few years ago. So we've come a long way. I'm really confident we will be able to deal with this, but it'll take a little bit of time and patience.
I also want to sort of talk about sort of our efforts here at the health system, the Cancer Center, in terms of COVID-19 research. I mean, I think KU, we pride ourselves in being leaders in research, not just in this area, but also in the country. And that's no different in the COVID-19 situation. So as you know, there actually is a COVID-19 research group that's been formed here at KU. And we've had lots of clinicians, we've had lots of researchers participate and collaborate in designing some of these important studies. I'll just highlight a couple that I've been aware of or know about. One of my faculty, Dr. Greg Gann, is actually working with a pharmaceutical company, potentially to bring a new drug to trial at KU for COVID-19 patients. It's possible, if this works out, that KU will be the first or maybe even the only center to have access to this drug for a trial, which would be very exciting. There's also other types of research that happen besides treatment and clinical trials. There's a study, I was actually on a call earlier this week with other cancer centers in the country. We're trying to design a study to see the impact of COVID-19 on cancer care across the country. And so how does COVID-19 impact treatment of cancer patients? How does COVID-19 impact the financial situation of cancer patients? And so we're in collaboration with many other cancer centers to do these national studies. So not only are we going to try to study if we can cure or treat this disease, but we want to study the impact of this on cancer patients as well.
You know, I'm just going to challenge you. What we want to see is no financial impact because you cured it. Isn't that a good plan?
That's a good plan.
That's the plan we want to follow.
And KU is going to figure that out.
And I would like to add, as far as we were talking about repurposing drugs, you know, as far as the general virology that we know about at this point, we think that the virus probably peaks at replication in your body at 7 to 8 days and then quickly goes down. And what happens later is maybe a huge inflammatory process or immune system dysregulation. So some of the repurposing of the drugs have been drugs you are very familiar with cancer treatment, and stopping some of those cellular pathways to block inflammation. So those are being looked at right now as well, several of them.
Questions?
I always have questions if nobody else has any.
All right, Nate.
I have some.
Please, go, media.
Okay, go ahead.
Thank you so much. And I'm sorry I had to jump on the call late because my laptop wasn't was not cooperating. But
Technology.
From the Kansas News Service, I know, right? So I don't know if you already talked about antibodies today, but I'm curious about is KU going to do antibody testing at all, and are there any kind of diagnostic, well, I mean, diagnostic isn't the right word, but is there a situation where you'd want to do that with a patient as opposed to like a broader population study? Or could you even use antibody testing to see which healthcare workers already have some measure of immunity?
Oh, that's a great question. And it is hard, and so I'm going to let both these guys, I'm going to start with Dana. I'm going to start with a little bit of math, though. So if the disease in the population is 1%. Let's say 1% of the population have had coronavirus, and the antibody testing is 99% specific, meaning it will only give you a false negative 1 in 100. But the disease only has 1 in 100 that's affected it. That means you only have a 50% chance of that negative test being true. It is just as, and that's the struggle with antibody testing, is that it may be getting better, although it can still confuse different coronaviruses, so you're not always sure you have COVID-19. But because the disease prevalence is still relatively low overall, the chances of false information are higher, Dana.
Yeah.
And you and I were, I think about 10:30 last night, he said, see, look, this article just came out from the CDC, I think, or something, to talk about it and address this very question.
Yeah, that's a great question. Certainly from the press conferences yesterday, from what I read later at night in recapping the press conferences, even I think it was Dr. Bricks who said that in the press conference that even the antibody tests now are probably not all hyped up that they should be. And that's kind of consistent with what we've been talking about for the last week or 2 weeks. We've had diligent work by Dr. Plapp and Dr. Leisman in our lab to help delineate this for us. But there's a lot of problems with these antibody tests right now, with serology tests. Number one, there are a lot of labs trying to make these tests. Some of these tests may not be validated correctly, meaning exactly what Dr. Stites said. If it says you have it or you've had it, then you've had it. Or if it says you don't or haven't had it, then you haven't had it. So some of these results may not be truly reflecting if you really did have the disease or not. In addition, we know that when you are infected, for the most part, you probably make antibodies at 11 to 14 days for some of these IgG-type antibodies, these long-lasting antibodies. But there is a subset of population that, even though they recover and get well, do not make antibodies at all. So there are a lot of caveats with this serology testing. And at this point in time, we continue to be consistent in saying we think there will be an absolute need, and we will use it for prevalence studies. But at this point in time, there hasn't been really good validated tests that we can use to determine that. And even if it were a very good test saying it was just SARS-CoV-2 that you were infected with and not some other common coronavirus, that still doesn't necessarily at this point tell us that you are immune to the disease. And even if you see the infection again, will you be infected or have a milder course? So that is still a lot of information that we really need to seek out.
So Dr. Chen, and by the way, Dr. Chen looks like he was in medical school yesterday. I, on the other hand, look like it's been decades ago, which is unfortunately is true. You're a Topeka guy. I mean, you're born and raised in Topeka, Kansas, and he's a very humble person. He won't tell you that he's actually incredibly well known for his research, especially around some kind of population health work. So talk to us a little bit about these antibodies. How would you see, assuming they could be accurate, how would you see them being applied?
Yeah, I think that's a really good question. I think the antibody test is very exciting, but I think the thing to emphasize is that the antibody test helps us look backwards. You've had the infection previously, but doesn't tell, which I think clinically is not as useful as the test we have now, which is you are currently infected or currently you're not. So is it useful clinically to know that somebody has been infected previously? Probably a little bit. And I think hopefully when the tests get better, we'll find uses for it. I can think of lots of really cool research questions for the antibody test. So if we know a certain population has been infected with coronavirus previously, which is what the antibody test will tell us, it can help us understand if they are more immune or less likely to catch it in the future. It can also help us understand if patients who've been infected previously had worse cancer outcomes or not. So there's a lot of cool research questions. But clinically, I think right now, knowing whether somebody is infected or is not infected, I think is a lot more important.
I agree. And are we going to be doing some research trials here at KU? The answer to that is yes. There is the convalescent serum, which is what this is kind of based on. It's, the convalescent means you're getting better, and the serum is that's we're looking for those antibodies to be used in patients with COVID-19, and we are part of a national study around that. So we are doing it, but it is where nobody really knows the answer to that. It sounds good. We want it to be true because we're all searching for that answer that will help make this disease less threatening, but we don't know if it's true yet, and there's some early hope, but we'll see. Okay, so which high school in Topeka, remind me?
Topeka West, Chargers.
All right, there you go. Where'd you come from, Hawkinson?
Rockford, Illinois.
Okay, see, what can you do?
Up near Chicago, so
all
go
right,
Bears.
fine. Oh, no, he can't come back on the broadcast.
Well, they're NFC. Go Chiefs. Chiefs are the world champions. They got the final word.
All right, next question. Hey, not hearing me.
If I could
Please, go ahead. No, please.
a little bit on the antibodies. I really appreciate all the information. So then my next question on that is, Secretary Norman says that Kansas is going to start doing antibody studies soon, and in several places around the state. So it makes me think that maybe we've already purchased this specific, test. I don't know, developed by whom. I obviously need to ask more about that. But then my question is are we doing this too fast when we don't have enough information about the value of these tests? Or what questions, would you guys ask of the state to figure out if this is going to be worth it, and give us useful information?
I think, and Dr. Norman will be on the show Friday along with Jerry Moran. So if y'all want to tune into our presentation then, that's a great time. It would be a great thing. We can ask him that question directly. We talk with him pretty frequently. I think that the answer really, we're all trying to figure out the role of antibody testing, but the way to do that is to get more research, get more tests, and then look and see how those results predict how people do in the response. So the answer is yes, we want to measure antibodies once we effectively know we're measuring the right ones. There are some machines that are a lot better than others, be especially suspicious of some of those. There's a lot of commercial kits out there, and you just got to be a little careful with those. I think looking at them in a scientific format is a little different because we're going to have done all the validation of those testing kits, and I know that Dr. Norman and the KDHE labs are doing exactly that. They do want to figure out the role of antibody testing because if we find that those antibodies are indeed protective, it means everything for how you can think about what workforce can go in front of patients who have COVID-19 and how do you protect folks. So I know they're interested in doing it. We're interested in doing it, and as I said, we started some studies here on it. I think some of our infectious disease guys are helping lead those studies, Dana.
Our infectious disease therapeutics group with infectious disease and critical care and pulmonary and ID pharmacy have all been really aggressive in trying to seek out some of these studies, including trial studies for drugs that we're trying to use, but also the serum or the convalescent antibody trials as well.
Other questions?
Hi, this is Nate. One more time. I have somebody who's asking, should we be weighing health outcomes of virus spread against health outcomes from depression, anxiety, and resulting from staying at home, job loss, sedentary lifestyle, etc.?
That is I'm going to say it's the elephant in the room, isn't it? Gosh, I'm a physician and help do administration and things like that. So I'd say I don't know. That's a political answer. Or what clearly, if you don't shelter in place and you don't keep your distance and don't do those things, and we were trying to reopen society, we would see a lot more COVID-19 all at once. And the volume of COVID-19 that we would have would overwhelm our healthcare system and our ability to handle that. There was a report coming out of Japan this morning because they had reopened society and they had controlled their disease initially, and they are concerned they've overwhelmed their healthcare system, and that it will see a lot of a breakdown of society. one of our physicians just came back from New York, and we'll try and get him on the show, and he could describe what he experienced out in New York City, one of our pulmonary critical care docs. And, it's unlike anything we've known. There is a great toll if we allow that to happen in our society from a healthcare perspective, because we will not be able to keep up with the amount of the burden of that disease. Now, I don't know how to answer the other part about the outcome of the economy and domestic violence and depression and anxiety, which is just true. And I don't know how you create that calculus. I know that we are looking every day and working with our political leaders locally and in the state and in the region to think about how we keep people safe so that society can begin to reopen. And I don't know that we have a perfect answer. We will not have a perfect answer. We will have imperfect answers. In that imperfect world, I think you do the next right thing that is in front of you. And even when we start to open society, which we'll have to do, and providing there's not a miracle therapy or cure or vaccination available, then as we reopen it, we still have to respect the rules of infection control to prevent the disease spreading. Because it will, if we unleash it all at once, we'll get through it. Well, actually, some of us will get through it, some of us won't. And the number who won't will be a lot higher than it is right now. And that's the challenge. And that's tough math. I don't have a great answer to that math. I don't know. Ron, Dana?
We have certainly said from day one, this virus will infect you, but it will also affect you. And it will not only affect you physically and your loved ones and your friends physically, but certainly psychologically, psychiatrically, emotionally, spiritually, because there are a lot of stresses. And this will bring out maybe new issues that nobody's ever had before because of what we're having to do to stop this virus. But it can exacerbate other issues as well. So it's a very real issue that we've been talking about for some time.
Yeah, good golly, Miss Molly, that is the question in the room. So, well, thanks everybody for being part of this today, and again, we look forward to our guests that are coming in the next few days. Again, Friday we will have Dr. Lee Norman and Jerry Moran, and that was a great session last week with Jerry, and I'm sure he'll have some good insights and current actions in the federal government. Dana, thoughts or about things today?
We are continually and tirelessly working towards evaluating new drugs, new therapies. As Dr. Chen has talked about, we have research groups here. We need to continue to decrease the amount of spread, as Dr. Stites continually says. Continue to stay home, social distance, wash your hands, don't touch your face, cough into your elbow. We need to continue to do things so that we can get out to more of a normal pre-COVID society and try to ease some of these other tensions and anxieties that are going on.
Dr. Chen.
Yeah, we've talked a lot about cancer patients getting treatment and keeping safe today. I think it's important for people to have high-quality, correct information. And so if people want to learn more about COVID-19 and cancer, the Cancer Center website, kucancercenter.org, has really good, high-quality information, and people can go there to read more.
To all of you out there, thanks for listening. Thanks for those great questions. The social calculus of our time, the challenge of our time, COVID-19. Be Kansas City, shelter in place, stay at home. 6 feet away, wash your hands, don't touch your face, and most of all, stay safe out there. We'll see you back tomorrow. And remember, there's no place like home.